Welcome for today's A to Z of CV pharmacotherapy series lecture. Today we would like to talk about Evolocumab, a PCSK9 inhibitor, and would like to know if it is a bride for the old faithful statin. So again, let me introduce myself. This is Franco Cheng, pharmacist at Yanchai Hospital Authority in Hong Kong. And the other moderator that will be joining me would be Associate Professor Doreen, who is a cardiology specialist pharmacist in Department of Pharmacy, National University of Singapore. Today, we're very honored to have Professor Heinz Drexel, Professor of Vorarlberg Institute of Vascular Investigation and Treatment in Austria. He will give us a talk on Evolocumab. And also we will have two panelists for case discussion. The first one would be Professor Alberto J. Lorenzatti, who is a co-director of Instituto Médico DAMIC Fundación, Rusculleda, the Investigación on Medicina of Argentina. Another panelist would be Professor Christopher Filipiev, who is a professor of cardiology of Medical University of Warsaw of Poland. So without further delays, there are some disclaimer and also housekeeping. This webinar will be recorded and will be streamed to Facebook and YouTube pages, and there will be CME point rewarded for those who are eligible. You will also receive your certificate and attendance upon completing a survey, which will be sent after the webinar. So without further delay, let's welcome Professor Heinz Drexel for his talk. Professor Drexel, please. Professor Drexel, you're on mute.
Can you hear me now?
Yeah,
perfect.
Okay. So thank you very much for the invitation and for the introduction to this talk, which is entitled "A Bride for the Old Faithful Statin." And I must say I'm a bit jealous because that was not my idea. And I congratulate everybody who brought this idea up, because this is very nice to think of a bride and of a groom in the treatment of this lipidemia. So if I can go on now, the title you have seen, and I thought we make this outline. Low density lipoproteins cause atherosclerosis. Some words on that. This is quite a new knowledge in this decade. Then I want to share with you the 4 steps to success. Then the groom comes in, statins, and then the bride. So let's get started with low density lipoproteins. And here you see a picture of the blood lipid transporters we have in our blood, and take this here as the surface of a fluid. And you see these particles, the lipoproteins, are not heavy. They are very light, and they float on the surface. And we have here a color of white, which is for triglycerides, and one of yellow, which is for cholesterol. And you see, if you go down this density gradient, you see the LDL and the HDL have mainly yellow, which means cholesterol. But if we look at LDL, we must say this is the most abundant particle class in our blood. So this is the main cholesterol carrier. And when decades ago we spoke about cholesterol, we did not know, but now we know that it is LDL, mostly the LDL particle. And then if we go now from this surface of our blood to the artery wall, then we see the artery wall in the inner layer has the atherosclerosis. And what was fascinating in research was that these little particles here, the LDL, were found in all their components also in the diseased wall. So the LDL, you can say, this is the particle that causes atherosclerosis, even from this picture. but you are scientists, you want to have more proof why this is causal. So, and I want to say LDL is not only causal, but also cumulative for atherosclerosis, because with the duration of life, we have more and more of these particles that enter the arterial wall. That's the word cumulative. Now, the evidence for causality was very early in epidemiology, pathophysiology, histology, animal studies. And what is very new in our century now is the Mendelian randomization studies. And let us focus a little bit on those. Of course, for us as physicians, the last line is the most important one. We must be able to have a treatment, and this treatment must be able to reverse atherosclerosis. That's why we are together today, because we have that. But let us shortly make a stop with Mendelian randomization studies. As you see in the headline, these are Nature's randomized trials. So we look at the genetic speciality of a patient and compare in a population those with low and with high impact genes. And then we see this very nice slide by Brian Ferentz, who compared all the different genes. NPC1 like 1 is the one gene where ezetimibe acts, HMG coenzyme R reductase, of course, is the statin side, and PCSK9 is our topic now. And if you look what is then the finding of this in this forest plot, it's always about 0.82 per reduction of 0.25 of LDL cholesterol, which is in milligrams 10. So this is very clear that we have different genetic sites where a reduction of LDL cholesterol can be mandated, and it comes out with the same result, which leads us to the conclusion, this 0.82, only the LDL cholesterol is crucial for our further considerations. Now, how could we now understand when we want to slow this process of atherosclerosis with interacting with the active point, namely LDL cholesterol? How could we do that? And may I suggest 4 steps? We have that from the literature. And an important link for this good marriage is the LDL receptor. So this will be a term that we don't leave anymore in this short talk. Because lowering LDL cholesterol by new drugs, we have learned that there is a 4-step way of success. First, we reduce intracellular cholesterol synthesis, mainly in the liver, but maybe also at other sites. This makes the cell angry, because the cell wants to have more cholesterol. And then the cell exposes the LDL receptor for, you could say, import of LDL or of cholesterol into the cell. By this way, we increase the LDL clearance, of course, from the plasma, and therefore we lower the plasma LDL cholesterol. A very fine 4-step process. If we now look how could this work, and we are already with PCSK9 inhibitors very shortly, we have this symbol here for the LDL receptor. You see it here, and this LDL receptor is there the LDL particle binds. But there is also something like a glue, namely the PCSK9. This glue fixes the LDL particle to the LDL receptor. So far, so good. But intracellularly now, the receptor and the particle can't be separated anymore. So in the endosome and in the lysosome, the receptor is degraded together with the particle. This is the important role of PCSK9 inhibitors, of PCSK9, and we have a very low number of LDL receptors. So if we now switch from here to here, and we say we now want to inhibit So we have the PCSK9 inhibitor here, monoclonal antibodies. They catch this glue in the plasma, and the glue is not able anymore to bind to the LDL particle nor to the receptor. The particle receptor couple now goes into the cell. The particle is degraded as before, but there is recycling of the LDL receptor, which comes back to the cell surface and again imports the LDL particle. So in summary, this is a very good thing to have this good guy of an inhibitor for the bad guy of a PCSK9 molecule. With that, we are now at statins. Statins are the groom for us, long already in our mind. And here you see the mode of action of statins, and by the way, also of bempedoic acid. And from the beginning, let's say, near to the acetyl-CoA, the cholesterol molecule is now built. And it is important that statins stop that building of cholesterol at an early step. So not many precursors accumulate in the cell. This is a very good principle. And as you already have now in your mind, this leads to the cholesterol is low in the cell. The cell gets angry or hungry, we could say, exposes LDL receptors. There is better clearance and the plasma LDL cholesterol goes down because the cell has now the particle. Okay, this is clear now. And now I want to share with you just some slides which you perfectly know, and look at this CTT collaborators, the most famous meta-analysis of LDL reduction and coronary events. And if you now look at this graph, you usually think from left to right you go up, but here you go down because this is an absolute reduction of LDL cholesterol that is depicted here. And on the ordinate, you see this is the event reduction. So from bottom to top, you have the better event reduction. So this is, as I said, the opposite of what we are used at from left to right, and from bottom to top, we go up. Here we have a reduction. And this could be summarized that a reduction by 1 millimolar LDL cholesterol results in about 23% event reduction. So this is a law of nature now. And we could say, well, if you break down the LDL cholesterol, like these disc breaks want to show you, then you break down the event rate. Okay, so the causality leads to this clear conclusion. And now in yellow, you see what we have reached by statins versus placebo, and we see clearly this is about 20% or 21 or 26%. But if we now go to high intensity statins, we see more of the good is more of the salvage of the artery and better for mortality, infarction, and major vascular events. So this is very clear for statins. Statins, the first ones that clearly showed that we can really attack atherosclerosis. So the faithful older man now finds a bride. And let us look at the bride. Here comes the bride. And if you remember what we first said about PCSK9, you can say if you have a gain of function of this bad guy, then you have high LDL cholesterol because you have degraded a lot of receptors and you have early atherosclerosis. The opposite, the loss of function of the bad guy, means you have a low LDL cholesterol because you have a lot of receptors that import the particles into the liver cell, for example, and you have atheroprotection. Good. With that, we have a short look at the famous Fourier study with the molecule that is in the focus of our interest now, and just to have a short glimpse on the population that was studied here by Sabatin and others. age 63, so quite young, 25% women. History of MI was the main inclusion criterion. Some diabetes, most already on high-intensity statins, a little bit ezetimibe because this was just published during that study, and the baseline LDL cholesterol was about 90. And now, if you look at the outcome, we see two fine lines for the primary efficacy endpoint and the more restricted secondary endpoint. And the next slide shows us what is the primary efficacy endpoint. It's the reduction of the major events, of course, plus unstable angina or coronary revascularization. And let us just insert some numbers here. We see there is an absolute reduction by 2%, 14.6 minus 12.6 is minus 2%. And this means this 2% lowering here at this time, after 2 years, it is 1.5% absolute risk reduction. This means this is a number needed to treat of 67, quite a good number of treatment. Please remember, these patients were also in the placebo group already on statins. So the 15% relative risk reduction parallels the 1.5% absolute risk reduction. Now, this is a quite complicated slide. This is Ebbinghaus. I just do not want to forget that. And here, the idea was to look when we go so low with our LDL cholesterol, can this be bad for our brain, which is anyway a rather stupid consideration because the brain makes its cholesterol itself, and no LDL goes into the brain, even in the healthy state. So if we lower LDL by treatment, I never expected that this is bad for our thinking. In other words, we do not need our LDL cholesterol at this moment, dear attendants, to think about LDL cholesterol, because our brain does not work with a fuel like LDL cholesterol, but with glucose. Anyway, I think we make this short. If you want to discuss it more, it's fine. Now, we are like in a movie of the marriage, and we have the screenplay of this marriage, and this is dictated by the guidelines. I show you here the ESC/EAS guidelines, and just very short one glimpse. We see we have different lipid-lowering agents, and you see them here. And if you look at their efficacy, the average LDL-C reduction, and that is from the original paper of the guidelines, then you see we had the moderate intensity, bridegroom, and then the high intensity. So we can go down by 50%, which is quite good. Ezetimibe added is a bit more. And PCSK9 inhibitor is another class of efficacy, about 60%. And if we combine that with, like in a marriage, with the high intensity statin, we can go very low. So if we attack the cause, and if we want to get off that cause, and if we take it as a toxin, of course, we want to marry those two drugs that attack the causal atherosclerosis mechanism. So from the guidelines, just a short glimpse, it is recommended to prescribe a high-intensity statin to the highest tolerated dose. And then for secondary prevention, patients at very high risk not achieving their goal on a maximum tolerated dose of statin and ezetimibe, then a combination with the PCSK9 inhibitor is recommended. So we could say that this marriage is recommended. And my last slide is this one. What we have learned in the last years is that whenever we use statins, of course, we inhibit the HMG-CoA reductase. So there is a reduction of the reductase as a result. Then we have seen that the PCSK9 production increases. So this is just a cell again that is used to these two molecules. And in the opposite, if we reduce the PCSK9, then the HMG-CoA reductase in term or vice versa is increased, which is a clear indication that we should combine those two. So the PCSK9 inhibitor is the bride, and the HMG-CoA reductase inhibitor, the statin, is the bridegroom. With that, I think we have now the dowry between the two, and by these two considerations we just had on the last slide, it is perfect to combine them and get from low causal toxic LDL cholesterol that is brought by one of them to a very low level, and I just showed you Ebbinghaus that is not toxic. With that, I think we have a happy couple, and I will be happy to go on now with your cases, dear colleagues from Poland and from Argentina. Thank you very much for your attention.
Thank you so much, Prof Drexel. That was a wonderful talk on the bride and the bridegroom, and no happiness, no dowry. That was perfect. The happy couple indeed. So we will invite any questions from any of the audiences. If you are interested in asking a question, please type into the Q&A function at the bottom of your screen. In the meanwhile, I invite Mr. Cheng, Franco Cheng, and he will take us through the cases and then pose various questions to Prof Christoph, Prof Lorenzatti, as well as Prof Heinz. Thank you very much, Franco.
Thank you, Professor Tan. So let's just a very quick recap. Thank you, Professor Drexel, for the very fruitful talk. And I'd like to go through the panelists again. We have Professor Lorenzatti and also Professor Vorarlberg for the upcoming cases. These two cases are actually real cases that I encountered during my practice. So we'll see how we should manage these new drugs, because the Evolocumab is relatively new in Hong Kong, I guess, and mostly other countries as well. So the first one is 81-year-old lady who had a history of simvastatin-induced myositis. So he has a history of diabetes, hypertension, and chronic kidney disease back in 2020, and she is currently taking amlodipine for her hypertension, aspirin and famotidine, and also Lasix furosemide for her edema. She is also receiving insulin and also Risonium A for her chronic kidney disease and diabetes. So back in 2020, she is not taking any medication for the lipid-lowering purpose. That's why back then, since we saw the LDL is so high as 4.5, acetaminophen was added at that point. But sadly, in April 2020, she encountered a stroke, and that's why the acetaminophen was taken off, and we started her on Evolocumab. And around 8 to 9 months later, we checked her LDL and found that the Evolocumab is so effective that actually reduced the LDL down to 1.8 millimole per liter or 7 milligram per deciliter. That's why the frequency was extended to every 3 weeks, and the sequence go on. We saw the LDL is well just above 1, and it further extended frequency to Q6, and then now she is actually receiving Evolocumab every 8 weeks. So the first question I would like to ask the panelists is that should we actually try to restart statin after the diagnosis of a statin-induced myositis or rhabdomyolysis back in 2020 instead of using acetaminophen? Then we can actually prevent a stroke incidence for this patient, this poor lady.
Professor Lorenzatti?
Yeah.
I think Professor Alberto put up his hand.
Yeah.
Thank you. First of all, I would like to congratulate Professor Drexel for such really excellent talk and the relationship between statin and PCSK9 as a perfect couple. Thank you so much. Regarding your case, it's a very, very interesting case. First of all, in fact, I would like to try again statins because I think the first intolerance episode occurred in conjunction with the utilization of nifedipine. I remember nifedipine is important inhibitor, is a potent inhibitor of cytochrome P3A4, which is a site of the catabolism of the, for example, simvastatin, atorvastatin. I would like to try, for example, with low dose of another statin, maybe rosuvastatin, which acts through another cytochrome, the 2C9. I remember it's the 2C9. Probably this patient can tolerate this other statin, and this may be a way to because we do not need to increase the LDL lowering, because the results of the administration of Evolocumab was perfect. The patient is reaching 1 millimole, which means that the second target for the second goal for the patient with recurrent events proposed by the European Society of Cardiology in the last guidelines. But I think because we have to use in a long way this kind of medication, I would like to try on re-challenge with a statin, just in order to prove if the patient can tolerate another different statin, like I would say rosuvastatin, and even we can use rosuvastatin 2 or 3 times a week initially. This is my point regarding your particular question.
Thank you, Professor
Thank
Alberto.
you.
I think the key point was the drug-drug interaction with amlodipine, with CYP3A4, and the possibility of the drug-drug interaction causing a higher level of statin. And I think Prof. Alberto is suggesting to use an alternative, which is like rosuvastatin, that is metabolized by CYP2C9 instead. Thank you so much, Prof. Alberto. I think Prof. Heinz as well as Prof. Chris are now waiting to answer the questions as well. Maybe we can hear from Prof. Heinz first.
Thank you, Professor Lorenzatti, for this interesting conversation and for your laudatio, I would say. I am exactly agreeing with you. We should try to have the couple here, and exactly we would also suggest, for example, 5 milligrams of rosuvastatin to combine, because we sometimes see some relapse under the PCSK9 inhibitor, and if we see that, it is fine to have it aboard. I also agree with you that this patient is at target at the moment and was not at target. If you look here, with 3 millimolar under ezetimibe, we know from all the studies that this is not enough a lowering of LDL cholesterol and stroke, then there is a high stroke incidence. That's a bad luck there. So complete agreement. I would also start, it would be nice to have a statin aboard, but it is not a must.
Prof. Chris?
I would also like to congratulate Professor Heinz Drexel for his great talk. And I also I'm agree with Professor Alberto and Professor Heinz with the comment. I think it's out of question if we should restart as a statin, because some guidelines are telling us that we should. So it's not a question of discussion. We should, after simvastatin-induced myositis. I think if it was simvastatin, which is the worst statin in a probability of myositis, you should really restart with statin, and rosuvastatin would be the best. But to say something different from other commentators, I would even nowadays, if I have such a patient with a very high risk, with diabetes, with hypertension, with chronic kidney disease, I would even challenge to restart with a combo drug. I would give her rosuvastatin and ezetimibe in a combo drug, I would think about a very low dose. There are combo drugs, for example, rosuvastatin 5 milligrams and ezetimibe 10. If not available in your countries, I would even try 10 milligrams rosuvastatin and 10 milligrams ezetimibe. And I think it would be also according to guidelines, because if you remember, in the last guidelines of European Society of Cardiology, we are saying about this subgroup of patients, I mean chronic kidney disease, that in this subgroup of patients, the combo the combo of statin and ezetimibe has first class of recommendation. It's because of a sharp trial in chronic kidney disease. So to summarize up and to say something different from other commentaries, I would restart, but rosuvastatin together with ezetimibe, and maybe it would be the way to postpone this stroke, or even to not to have a stroke. And of course, Evolocumab was a great success in this patient. We know that after the stroke, the recommendations say that this lady should have LDL below 55 milligrams. It means below 1.42 millimole. And I would say that I'm from Poland, and in Poland we have a Polish recommendation, and we even have not only very high risk group, but we have also the definition of extremely high risk group. And in extremely high risk group, we have, for example, patients who have atherosclerosis in different vascular beds. So, for example, if this lady after stroke has a coronary atherosclerosis or cervical atherosclerosis or peripheral atherosclerosis, then her goal is not below 55, but below 35 milligrams per deciliter. 35, it means 0.9 millimole, and such are the guidelines in Poland of Polish cardiovascular group of Polish Cardiac Society. So I think that will be really very, very low. Yeah, it's like you are now drawing 0.9, so it's below 35. I know that in European Society of Cardiology guidelines, there is maybe not a defined extremely risk population, but they are saying that if you have the second major cardiac events, you can go below as 1 millimole, so 40 milligrams. In Poland, we are saying 0.9, so 35. It was also adapted from many meta-analyses, including Fourier trial also. That is my comment. Thank you.
Thank you, Professor Chris. Everyone is so enthusiastic about the bride today, right? Yes. So I just wanted to make a quick comment. I think in Asia, we're a little bit more worried about the use of high-dose rosuvastatin. So I think your suggestion of using a low-dose rosuvastatin and maybe ezetimibe is a good one, because then we can use that combination as well to lower LDL even more effectively without trying to go a bit too high for rosuvastatin. I think, I'm not sure about Franco in Hong Kong, but this is an 81-year-old female. I think this is something that in Asia we're a bit worried about when we use high-dose rosuvastatin, especially for females and elderly.
Absolutely, I agree with Professor Tan. Yeah, we're also very conservative when starting statin. Actually, although we know that simvastatin wasn't the best statin that available, but it's still very frequently used right here, because some of our patients are actually very sensitive to simvastatin, and they can actually achieve high intensity statin reduction, believe it or not. I don't believe, but it turns out the lab actually doing okay with simvastatin 20 milligrams. Sometimes it's very amazing right here. Anyway, I guess the panelist has also commented on this as well. Should PCSK9 inhibitors be used as first line for these cases? I guess Professor Heinz Professor Drexel has mentioned that she probably start rosuvastatin and other kind of statin before using the Evolocumab. But sadly, for this case, I guess Professor Chris has mentioned there is a specific target for this patient, which is also some of the audience actually asked about the lowest LDL that we would target for patients. I guess in Poland that you guys will actually target at 0.9 millimole per liter or 35 milligram per deciliter. May I ask, is there any other comment from other professors? Professor Drexel?
Well, much of our strategy is caused by history. We first had the statins, then ezetimibe, and then PCSK9, and we added one to the former. So if we had PCSK9 inhibitors at the beginning, probably it would also be very good to start with a PCSK9 inhibitor, but the guidelines, they follow the evidence, and the evidence has a history. That is, I think, if you're a patient and she is old, but she is clever, if she doesn't like to take another statin, then it is just like you started. It's perfect. And if then you end up with PCSK9 inhibitors only, you have not a marriage. Perhaps that's why we want the statin to be also aboard, but it is fine to stay with the PCSK9 inhibitor alone. Please, we should not forget the age of this patient, and LDL is not only causal but also cumulative. So the time for further accumulation of LDL in this lady is probably not very long, perhaps 10 years or so, if she does well after the stroke. So we should just consider the age also a little bit, so not overdo it. And then she has a lot of polypharmacy, we could say, and our pharmacists are excellent ones here in this panel. And perhaps you would also suggest not to do too much with this not so young lady.
Thank you. What about Professor Lorenzatti? Do you have any comment on the target of this patient?
Yes, I think if we follow the guidelines, and you know, guidelines are strongly supported on evidence, this is a proper target. But think about the patient decrease her LDL cholesterol more than 50%. This is an important point. I will be comfortable with reaching this point, or even a little less, because it's an old woman. The polypharmacy that Professor Drexel has mentioned is also an issue with this kind of patient. I think I would like again. I would like to try with a statin. If it's not tolerated, I would maintain the administration of Evolocumab, which is a drug very, very well tolerated during time that we have observed the clinical trial and in a real world up to now. But I think I will be again comfortable with this around 1.2 or even 0.9 millimoles per liter regarding her LDL cholesterol.
Thank you,
Professor.
Prof.
Yeah, thank you, Prof. Sorry,
Thank you.
Thank you. Yeah, I guess the key point would be around 0.9 to 1.2 would be your target. I saw Professor Filipiak has actually want to comment on that, right?
Yeah, of course. I also agree with Professor Alberto. But one thing must be said. I think while we are talking about the guidelines, and guidelines are saying that after stroke you must have LDL below 55 at least, and 50% of reduction of LDL cholesterol. And I would like to once again to underline that there is a big difference between guidelines from 2016 and 2019. Because if you compare the guidelines in 2016 were saying, like Professor Alberto said, well, you must reduce the cholesterol of 50% and or reach the target. And now in 2019, we are saying you must reach the goal and reduce. So you don't have the word and or, but you have the word and reduce the LDL target of 50%. So in conclusion, the lowering LDL by 50% is not enough nowadays. You must reduce 50%, but also you must go to the goal, to the LDL goal. That's my only comment. Thank you.
Thank you, Prof.
Thank you.
Chris. It sounds like maybe in 2016, the bridegroom has not found the bride yet, but now in 2019, he's found the bride. So therefore, we are able to be a little bit more aggressive with the LDL goals. All right, maybe we could ask Prof. Koji's question to either one of the panelists. Prof. Koji wants to know whether the absolute LDL level or the extent of reduction is more important. Like if the LDL level is lower than 70 at baseline, should we administer statins to further reduce LDL? So is that important to you as well? Would anyone like to take the question? Maybe Prof. Alberto?
Excuse me?
The question from Prof. Koji is the absolute amount of reduction of LDL important, or is it the extent of reduction that's important? If you had a patient whose LDL is about 70 or lower, do you still administer statins to reduce the LDL even further for secondary prevention?
Of course. I agree. I would like first to agree with Professor Philip because the last European guideline stated the two conditions: less than 55 milligrams per deciliter plus 50% reduction regarding the level of LDL. Regarding the question of Professor Koji, I would like to increase the LDL reduction, for example, in this case, up to less far below 55 milligrams per deciliter. I think 1.40 milligrams per deciliter, which means 1.0 millimole per liter, is a good objective LDL objective for this patient. I will be really comfortable with this level because think about in the Fourier trial, there were near 500 patients who achieved levels below 10 milligrams per deciliter, in average 7 milligrams per deciliter. In the 2.5 years of the duration of the study, there were no safety concerns about this patient, and there were more benefit in terms of event reduction in comparison with the entire cohort. I agree with Professor Koji that I would like to go further with the LDL reduction. In this particular patient, I would like to maintain around 1.0 millimole per liter.
Perfect. So Prof. Alberto thinks that we could still use the solo statin as a solo bridegroom, even if he hasn't found the bride, as long as the LDL has been lowered to 55. I think Prof. Drexel has a comment.
I could show from the cholesterol treatment trialists data, the meta-analysis upon statins, that the absolute reduction of LDL cholesterol was the best predictor of the outcome. This is a very important knowledge from that type of meta-analysis. And we speak about percentage reduction now, which is perfectly good. But if you want to have, and this was asked by our discussant, if you want to have the best predictor, look at the absolute difference you have before and after treatment. That is typical also for the population and also for the patient. So the absolute reduction. If you go down, like here, you could say from 4.5 to 1, that is an absolute reduction of 3.5 in LDL cholesterol by millimolar. So this is very good.
Thank you, Prof. Drexel. There was another question from the audience, Wei Xiang. He wants to know if there's any major difference between the different PCSK9 inhibitors and also the new agent inclisiran. Maybe Prof. Chris can take the question.
Hello? Yeah, you asked me.
Yes. Is there a
Yes.
difference between the different PCSK9 inhibitors, Repatha and Praluent, and the new agent inclisiran?
Well, we know that probably there's a class effect. I think that we agree that there's a class effect between Alirocumab and Evolocumab. And of course, there are some differences in clinical trials outcomes, but they can be referred rather to the clinical characteristics of patients included into Odyssey outcomes and into Fournier. So as a cardiologist and also as a clinical pharmacologist, I would say that probably there's no big difference between Evolocumab and Alirocumab. The more interesting question is there a difference between inclisiran and those drugs? And I wouldn't be so sure if there is a class effect, because this is not the same class of drugs. I think they are totally different, because the mechanism of drug action is totally different for inclisiran and for Alirocumab and Evolocumab. And if we are talking about this particular lady, which is 81-year-old, well, I would say maybe I will reconsider inclisiran only because it can be given once half a year. That would be really important for such a patient with a polypharmacy. But I know that not all over the world this drug is available now. So in some countries, we must stick to the traditional. Well, it seems different to say, but it's strange to say, but we should stick to older PCSK9 modulators. So I mean inhibitors, Evolocumab and Alirocumab. That would be my comment.
Thank you. Thank you, Professor, for your comment. I saw Professor Drexel want to supplement.
This was an excellent question from the audience, and the answer is quite simple. If you remember Brian Ferencz and his findings of the 0.82 relative risk, then the important is where you reach your LDL target. And it is very clear we should then see that the LDL cholesterol is low. The difference between Fourier and Odyssey outcomes was probably not much in pharmacological sense, but the population was different. Odyssey outcomes was ACS patients only. So if you find a difference between two trials, please also remember that you have two different populations. And from Odyssey outcomes, perhaps we can stop a myth on statins. There was also a suspicion, or always a suspicion, that we could have more hemorrhagic strokes with statins. And this was always wrong. But now from Odyssey outcomes, we have a publication in this ACS population that by the PCSK9 inhibitor and going so low with LDL cholesterol, we have not the least increase in hemorrhagic strokes, but we have a 28% reduction in ischemic strokes, even in patients with the ACS in the first year after the infarction, for example. So I think the question was excellent. The answer is easy. It is certainly the same. And with inclisiran, we are still waiting for the outcome data, but probably it will also be pretty much the same.
Thank you, Professor Drexel. I saw Professor Alberto has some comment, but we are very tight in our schedule. Yeah.
Just a brief comment.
Yep.
Yes, a brief and practical comment. Alirocumab has two doses, 75 and 150 milligrams, and Evolocumab also two, but 140 milligrams and 420 milligrams, but for the monthly administration. The result is quite similar, but it's not available in all countries, the last one. But this is a practical approach.
That is true.
Thank
It's not
you,
available in Singapore as well, the monthly one. Go ahead, Franco.
Yeah, sorry. Since we're very tight on the schedule, and actually we are planning another pharmacotherapy series on inclisiran. So please stay tuned and join us soon. For the very last question, which would be about the frequency of the Evolocumab, because we know that it's not a licensed indication to give Evolocumab every 8 weeks. So do you feel it's not comfortable to give this drug at such a long frequency? And how could we ensure the compliance to that regimen as well? Any comment from the panelists for that about the extended frequency of Evolocumab? Yeah, Professor Christopher?
Well, in fact, we don't have the clinical data for extending the frequency of Evolocumab, and from the legal point of view, it should not be recommended. I mean, we don't have the data which can back up this. That's my opinion.
What about Professor Alberto?
Yes, just agree. There are no data, but there are data regarding the ups and downs with the LDL levels. I remember during the development of the Evolocumab, I was noticed about some investigations regarding that. The bottom line is it's not a good thing to have ups and downs in the LDL level. That is probably may occur if you extend more than 15 days the administration rate.
Thank you. I guess I'll probably need to discuss with the doctor to see if we should change to another medication for this patient. Well, let's move on to the next cases. We have this time a relatively young male, Mr. Ng, who is a smoker and a very strong history of ischemic heart disease. So actually, he has on and off chest pain with a normal sinus rhythm ECG. The triglyceride is elevated, but he actually refuses to take any medications because he thinks that could be controlled with diet without any medication help. He has done a treadmill back in 2019 in September, which is positive with a baseline T-wave inversion over V3 to V5 lip. So the first question I would like to ask is that it is appropriate. What's the role of fibrate in nowadays? Because we mentioned a lot about LDL and also the HDL, but we don't have much time talking about triglyceridemia. What are your comments for using fibrates or the management of hypertriglyceridemia? Professor Alberto, please. I saw your hand is still up. Oops. Sorry, Professor, are you on mute?
You're muted, Professor Alberto.
Thank you. The fibrates are very useful, I would say, in this kind of patients because the level of triglycerides is quite high. Everybody knows that there is no strong evidence regarding the use of fibrate and the reduction of cardiovascular events. We are waiting the results of the prominent study. In this study, the drug in use is pemafibrate. It is a different, it's more potent and very selective PPAR alpha agonist. But I think, remember, in the vast majority of the trials with fibrates and statin, the subgroup that showed triglyceride elevation and low HDL, this subgroup showed a very good result in terms of risk reduction, but it's just subgroup, it's not the entire trial. But in the clinical practice, the use of fibrate is useful. The only thing that you have to take in account is the renal function, and you have to combine only with a statin, a fenofibrate, or fenofibric acid because gemfibrozil is really absolutely contraindicated. I would be in favor of the utilization of a fibrate in this particular patient.
Professor Christopher has some comments for the management of hypertriglyceridemia, right?
I agree with Professor Alberto. I would like to say that in my country, of course, the only fibrates that we use is fenofibrate. We don't have other fibrates, and that's reasonable because fenofibrate has the lowest risk of drug interaction with other drugs. And in fact, in many cases, we try to treat those patients like this. So statin plus fenofibrate if you have hypertriglyceridemia. That's according to guidelines. Guidelines are saying that statin is the first choice. Fenofibrates, well, maybe it's not the second choice because according to guidelines, omega-3 acids are the second choice. But in fact, we are in Poland using fenofibrate more often, mainly due to the fact that omega-3 acids are quite are not cheap drugs because in fact to reach triglycerides goal you need to at least to use 4, 5, 6, maybe 8 grams of omega acids to reach such triglycerides. And one more comment, we are saying that of course we don't have good evidence-based medicine for fenofibrate for lowering cardiovascular risk, for lowering cardiovascular risk of death. But I would like to remind you that recently, I mean last year, we had the publication of a follow-up of ACCORD trial, that's accordion, so it's follow-up of ACCORD. And in this follow-up, fenofibrate, when added to statin, also lowered the total mortality. So the mortality without with all the reasons. So I think that evidence-based medicine for fenofibrate is getting better and better.
Thank you, Prof. Chris. I completely agree with you with this standpoint. I think Prof. Koji also has mentioned about the triglycerides being too high and there's a risk of pancreatitis. I think my very own father was also in this state where he drank a lot of alcohol at one time and had very high triglycerides and also went to pancreatitis. I think Prof. Koji is asking for more information on the HDL and whether the person is diabetes. I think that's a very fair comment because a lot of times when we see people with poorly controlled triglycerides, it's also when they have got poorly controlled diabetes. And if we control the diabetes better, sometimes the triglycerides also get better. I think that's also related with the question from Bunga as well, whether there's a role in VLDL. But maybe we'll let Prof. Drexel comment first and then pose the next question to Prof. Drexel as well. Thank you.
Well, we are short in time now, I think. This patient has chylomicronemia. This is quite different from the LDL disease. And this patient is probably in primary prevention, and he would be an excellent patient in ACCORD or FIELD. In both trials, he would be the one in the subgroup that responded very well. And also the REDUCE IT trial we had recently on omega-3 fatty acids, and a specific one would favor him to get omega-3 fatty acids. So I have some patients with that pattern. I first treat them with fenofibrate and omega-3 fatty acid. And if I then see that the LDL is elevated, then we add a statin or something else to reduce LDL cholesterol. So it's a quite different field. If you remember the picture of the blood in one of my slides, that's just the one on the very left side is the chylomicrons. They are not directly atherogenic.
Oh, actually, the audience of Bunga actually asked about the VLDL on the atherosclerotic plaque progression. Any comments on the triglyceride and also the VLDL for this patient as well? Professor Drexel?
Yes, that was what I just said in the last sentence. This is more than VLDL. It's also VLDL and it's chylomicrons. So this patient is in a permanent, highly postprandial state. And of course, the diet and the omega-3 fatty acid and the fibrate would be the good combination for him. And also to stop smoking, because smoking reduces HDL cholesterol further. So we have a very good further idea to stop smoking with him.
Well, thank you. So let's carry on the cases. Actually, after the using fenofibrates and atorvastatin, his triglyceride actually improved a lot. And then finally, we got the LDL because previously we could not calculate the LDL level based on the very elevated triglyceride. That's why the doctor further started Evolocumab for this patient. So do you think there is a role of PCSK9 inhibitors for the TG management, actually?
I'm not sure. I'm not sure.
What about other professor? Professor Alberto, please.
Well, there is, in my opinion, there is no specific role of the PCSK9 inhibitors in the management of triglycerides. But in several studies with mild hypertriglyceridemia, we have observed some reduction. In fact, this year we published in cardiovascular diabetology the information, the data from 2 studies with Evolocumab, the Berson study and the Banting study. We gathered around 1,400 patients. All were diabetics, all were on statins, plus Evolocumab or placebo. There were a VLDL reduction of about 20% in general, and there were cholesterol remnant reduction of about 35%. But we divided in 3 groups. All patients were diabetics. Patients with all with high LDL, of course. High triglycerides and low HDL, and normal triglycerides and normal HDL. In the first 2 groups, there were a reduction in VLDL, as I mentioned before, and in a very interesting way, cholesterol remnant. I would repeat, near 35%. For this reason, I think it may be a complement if we need a further reduction of cholesterol, of LDL, the administration of PCSK9. But at the bottom line is, in my opinion, there is no specific role of this kind of medication is in patients with high triglycerides.
Thank you, Professor. Yes, Professor Christopher, you have comment on that as well.
I of course agree with Professor Heinz and Professor Alberto, but once again, maybe for the seminar and for our listeners, is quite interesting that in fact, we know one monoclonal antibody, which is great in lowering LDL cholesterol, and it's even greater in lowering triglycerides, and it's a newly registered in USA by FDA, Evolocumab. So Evolocumab, so the drug that is with totally different new drug group. I mean, the drugs that are related to angiopoietin-like peptides. So it's this drug, which is really very, it's not a cheap therapy. It's really very not available in many countries for many years, I think will be. But this drug can really allow LDL and hypertriglyceridemia, and maybe it would be the drug of choice for such patients as the patients presented.
Thank you, Professor. So let's move on for the very last question. Is about is there any patient that is not responding PCSK9 inhibitors? Because we saw this patient actually did not have a very significant reduction in LDL after starting Evolocumab. So is it possible that someone is actually intolerant? I'm not saying intolerant, but not responsive to this new class of medications?
Metabolically, I think these patients have also now more LDL because the VLDL to LDL process is increased, of course, by fenofibrate and the other drugs. So all of a sudden, these patients have now more LDL particles in the blood because of the shrinking of the triglyceride-rich lipoproteins. So I would not say it is a non-responder, but there is now a higher load of LDL. And I have seen one patient only who exactly had that problem. So I would not say it is a non-responder to PCSK9 inhibitor, but the new basal LDL is higher.
I see. So what about Professor Christopher? What's your comment apart from being a high baseline?
My comment will be that I'm from Poland, so a very Catholic country, and therefore I should be thinking only about one bride and one bridegroom. But in fact, in such patient, we should a marriage of three. So in fact, in such patient, I must be sure that it will be statin, ezetimibe, and PCSK9 inhibitor. So two brides and one bridegroom. As we remember from the meta-analysis, such three-member couple will give us at least 85% of LDL cholesterol. So this will be my first comment. My second comment, on the contrary to Professor Heinz Drexel, I never have come across such a patients who don't respond to PCSK9 inhibitor. But if I do in the future, I would think about changing PCSK9 inhibitor for inclisiran, because this is a little different mechanism of action. So I would try another class of drug. So it would be like this. I would try this. Thank you.
Thank you, Professor Christopher. And I saw Professor Alberto want to comment as well, right?
Yes, regarding your initial question, the answer is yes, there are people apparently not responding to PCSK9 inhibition, but there are really very, very few. In the clinical trials, there were about less than 1%, 0.5% patients that do not respond to PCSK9 inhibitors. The reasons may be different reasons. For example, the most common, you have to discharge bad adherence or poor adherence, or the fact of the not correct administration. But besides that, there is some data regarding maybe an alteration in some patients, very few patients. This is a theory in the site where the monoclonal antibody combines with the PCSK9 particle. But anyway, the other more common reason may be homozygous FH, for example. But the last comment is regarding maybe also the possibility that the patient has high LP(a). This is not the case, I think, but this is another possibility. And the last one, the development of ADA, anti-drug antibody, but there was not really a correlation between the presence of anti-drug antibody and the lack of response to the PCSK9 inhibitor drug. Anyway, the bottom line is very respond to the PCSK9 inhibition, but can occur.
Thank you, Professor Alberto. I think we lost you a little bit at the end, but I think you kept saying it was very good. We must have this bride for the bridegroom. All right. I think we had a very vibrant discussion, and I'm sure you will agree with me. I think all the professors were all wonderful in offering their opinions. I think, Franco, I learned a lot. I don't know about you. Yeah. So I think we should let
Same.
our audience go because it's already past 7 p.m. So thank you everyone for joining us this evening, and our very beloved panelists, the professors, Prof Drexel, Prof Filipiak, as well as Prof Lorenzatti. Thank you so much, everyone, and have a good evening. Bye.
Thank you.
And good
Thank you.
night.
Bye-bye.
Bye-bye.